Welcome to this bonus session of the WMS PATS PSA prep course. What we're talking about today is IV fluid. So this is a bonus session that we couldn't quite fit into the normal program. So you're getting this on your screens instead. So you'll see me pop up around the screen here, maybe slightly above myself, and in other places throughout, just to keep you interested throughout the video. So essentially, what are we looking at today? We're looking at PSA practice for fluid prescribing. You're going to get a chance to prescribe for 3 different scenarios. All of these could come up in the PSA. It's a section that is good to get right. Remember, you're going to have at least 2 out of the 8 questions. The prescribing section are going to be about fluids. It may also feature in other parts. What we're not going to be covering today is what to do when your patients are dehydrated but shouldn't be started on fluids, or when you shouldn't start fluids. Dehydration, how to wean people off fluids, fluid assessments, complex prescribing. Everything is generally going to be quite straightforward, simple stuff that you might expect to see in the PSA or might expect to see as an FY1. So without further ado, we'll move on to the first question. You have a 37-year-old man who's been admitted after a stroke, who is now nil by mouth until their review on Friday. So you may be seeing this on a Tuesday, due to strike action. He has no significant comorbidities. He weighs 70 kilograms. He's now nil by mouth. So you've been asked to prescribe him some fluids for the next 24 hours. So what you can do now is pause the video and have a go at prescribing some fluids for this patient. Alternatively, we will be doing it together in a couple of slides. So what I'd recommend is you can pause the video here, have a go. We'll talk about some basic principles for prescribing fluids, and then I'll give you a little bit of help of how I might approach doing this question. So hopefully that's enough time for you to have paused the video and unpaused. So one thing to think about when you are approaching fluids is the indication, and that's something that will help you massively when trying to navigate the enormous amount of nice guidance that is available on this topic area. So something to think about is, why are we giving these fluids? Is it for resuscitation purposes? So that's when you're thinking about your patient in some kind of hypovolemic shock, and fluid resuscitation is going to improve them. Also, you may be thinking about replacement, and we'll come to that in just a second. But also routine fluids. So are we just taking care of their daily needs when they're not eating and not drinking? Their fluid requirements, their glucose requirements, electrolytes, we're just taking care of those. If it's not their basic daily requirements and it's not for resus, and it's somewhere in the middle, so perhaps they're sick, perhaps they're dehydrated, they've got AKI, perhaps they are, they're not unstable, but they're not healthy either, really, and electrolyte derangement or dehydration, we're taking care of complex things, and you're sitting in the remit of replacement. So we'll be talking about that for the bulk of the session, but we will touch on the other two shortly. So looking at resus fluids. Resus fluids, essentially, it's 500 mils of saline over 0.9% over less than 15 minutes, or STAT. I believe you can write both of those in the PSA. Now, when it comes to resus fluids, the reason why I've made this the headline is this is what the NICE guidance tells us to give in any acutely unwell patient, really, that are showing signs that they might respond to some fluids. So what does that look like? I'm sure you guys are already aware, and I don't need to tell you, but I've lifted these from the NICE guidance for your own convenience. So features that suggest that they may need urgent fluid resuscitation include a low blood pressure, the tachycardic above 90, cap refill time more than 2 seconds, respiratory rate of more than 20, NEWS over 5, passive leg raise test. I'll direct you to kind of read up at that in your own time. But all these are signs that the patient may respond to fluid. So what do? We give them a 500 ml fluid challenge as quickly as we can, really. And a suitable response, we're looking at signs that they've improved as a consequence. So, your pulse has decreased, your blood pressure's come up, or your urine output's risen. So I don't really need to reiterate. I'm sure you guys are already aware. So we'll move on to some more interesting stuff. So, now you're looking at routine replacement. So what exactly are we replacing? So you're replacing fluid, you're replacing electrolytes, and you're replacing some glucose. So how much do we know how much should we be giving? So fluids, essentially, we need to be giving 25 to 30 mils per kilogram per day. Also with electrolytes, it's quite straightforward to remember. All three of them are 1 millimole per kilogram per day. And you may be wondering, how are we going to deliver that? So one bag of saline actually contains 154 millimoles of sodium chloride. That's 0.9% sodium chloride, just to clarify. Potassium, for instance, now with that, you may find a little bit lingering in your Hartmann's, but also usually when you prescribe it, you're almost prescribing it as though it's being added separately. So it'll be your normal saline bag of 1 liter, 500 mils, or a dextrose bag of 5% with there may be a liter, and you may be requesting 20 millimoles of potassium or 40 millimoles of potassium. Now you are constrained by what the manufacturer provides and with what you have available in your department. So usually these will come as bags of sodium chloride with 20 millimoles of potassium added or 40 millimoles of potassium. What you should never be doing is injecting potassium directly into your bag. As far as I know, that's a never event. It's not something that should be happening, and it's not something that I'd advise you to do. Peds land may be a little bit different, so I hear. And finally, you've got glucose. So glucose requirements are 50 to 100 grams per day. So remember that we covered in our calculation session, 5% means 5 grams per 100 mils. In 100, if you want to meet those daily requirements, for instance, the bare minimum of 50 grams per day, you're looking at something like 1 liter, because we've got 50 grams in 100 mils, 5 grams in 100 mils. So therefore, to give 50 grams, we'd need to give 10 times that, which is 1 liter. So for example, now we've got a 50 kg patient, so they sit in the region of needing 1.25 to 1.5 liters per day. That's 50 millimoles of sodium chloride and potassium, and 50 grams to 100 grams of glucose. So what you might notice is really one bag of saline, 1 liter, has more than enough of your daily required sodium and chloride, which is something you want to think about, especially when you're prescribing fluids to a patient days on days. If they're having 3 or 4 bags a day, or 2 or 3 bags a day every day, are you overloading them with sodium? So just to reiterate, this is a good time to mention it, really, is that anytime you start fluids in a patient, it's really important to monitor their electrolytes and also monitor their urine output and see how they respond to the fluids that you're prescribing. And we'll be talking about glucose prescriptions in just a second. So let's have a look at what our fluids look like. So comparing our Hartmann's to our sodium chloride, you can see Hartmann's has less sodium in it, it has less chloride in it, it has a little bit of potassium in there and some lactate, and this helps deal with some of the risks that we have with sodium chloride. For instance, something like hyperchloremic acidosis, that is something that less likely to occur, since we aren't having that loss of bicarb in order to get rid of the chloride that can precipitate the acidosis in your patients. Similarly, if we look at dextrose, it's actually hypotonic, meaning that it's not a very good hydrating tool. A lot of the fluid that we will prescribe will end up leaking into third spaces, leaking into interstitial places. Very little of it will actually remain in the vascular space, whereas that's something that our sodium is very good at doing, since it's isotonic. Or similarly, our Hartmann's, it's isotonic, so it keeps our fluids within our vessels. So let's have a look at what the BNF suggests. So if you have a look at this page in the BNF, you should be able to Google this, or search for this on the fluids and electrolytes section of the BNF, and it'll give you some advice about oral rehydration and oral resupplementation of those derangements. So for instance, for potassium, you can always give Sandoz-K as an alternative to bring the potassium up. But also, let's have a look at what is available parenterally. So if you scroll down to the bottom of the page, you may see some preparations available, and it'll tell you what is available essentially for you to prescribe. And just below that also is a very interesting section about evaluating high output stomas and the kind of fluid and electrolyte losses you get based on where your stoma is. So whether it's a jejunal or whether it's colonic, you will get different rates of electrolyte loss, and it's something that you can use to estimate your replacement. So looking at this, so you've got sodium chloride 0.9%, That's 150 millimoles per liter, along with our chloride. So that's quite box standard. You've got our sodium chloride 0.18% with glucose. So this really is hypotonic. So it's not going to be quite as hydrating as our sodium chloride. But similarly, it's maybe a good workaround for if you want to give your sodium chloride and glucose, but you're fluid restricted. But in the PSA, I would say maybe scratch this and stick to your isotonic solutions. You generally will not go wrong with them. Okay, so next, having a look at some of our potassium options now. So sodium chloride comes with potassium chloride is 0.3%. What that looks like is 40 millimoles per liter. And we have a little bit more chloride in this. Similarly, we've also got, ignore this, let me just rub that for you. We've also got potassium chloride in our dextrose. So that looks like 40 millimoles of our potassium and 40 millimoles of the chloride. And remember, we've got our 50 grams of glucose within this also. Next, we've got our compound sodium lactate, our Hartmann's. So with Hartmann's, we have a little bit of potassium, but remember, the one unique thing about Hartmann's is the fact that we cannot add potassium to this. So when you're prescribing, here's some possible options that you may want to prescribe. So you may want to prescribe, of course, you'd add the volume, but normal saline 0.9% plus 20 millimoles of potassium, normal saline 0.9% plus 40 millimoles, or similarly 10% dextrose plus 40 millimoles. So going on to prescribing potassium now. So prescribing potassium, there's two golden rules that you must follow when prescribing potassium. One is you can only concentrate potassium to 40 millimoles per liter, especially if you're giving it peripherally, because there's such a risk of damaging local structures. So you cannot concentrate it more, and it shouldn't be available in a more concentrated bag available on your general day-to-day wards. On ITU, things might be a little bit different, but it's something that you can't really concentrate more than that. So when you're theoretically prescribing, remember that, if you're giving 500 mils, don't give more than 20 millimoles, as an example. And similarly, along with that, the second rule is about rate limits that we have to the potassium. So you cannot exceed more than 10 millimoles per hour. So for instance, if we were to give a bag with 40 millimoles of potassium, that's a 1 liter bag. We cannot give that 1 liter bag more faster than 4 hours. Similarly, if it had 20 millimoles, we couldn't give that faster than 2 hours. I'm sure you get the idea. Generally, you can only prescribe it in 20 millimoles or 40 millimoles. Now remember, the other thing to remember, another option for sodium is another option for potassium is our Hartmann's solution, and that contains 5 millimoles of potassium, so that's something to factor in when you are prescribing. With our glucose, generally we don't need to prescribe glucose unless we're confident that a patient is going to be nil by mouth for several days and they're definitely not eating, so we need to top that up somehow. So they're available as 5%, 10%, 20%, but just remember, the more concentrated you get, the more you're turning into liquid honey. So it does have a risk of clogging up your cannulas, but it could be a good solution if your patient, again, is fluid restricted, but you do need to top up their their glucose quite quickly. Remember, it's hypotonic, so it's not a very good hydrating solution. It may fluid overload your patient. It can also cause hyponatremia or make hyponatremia worse. So before you prescribe this, check to see if your patients are hyponatremic. So now getting on to some fun stuff. So this is our first, similarly, as you can imagine, hyperglycemia. So now our first question. So going back, I have very kindly now provided the requirements of this patient. So they require 1.75 to 2.1 liters, so maybe you can aim for around 2 liters, 70 millimoles of each of the electrolytes, and 50 grams to 100 grams of glucose. So get creative, have fun, have a go, use your BNF, think about what options you can give this patient and whether you're meeting their daily requirements draw a table if you need to. That is something you can do. So I will reveal my solution very shortly. So hopefully you've had a chance to have a go at that, and now I'll unpause. So this is one solution I came up with. So that was 5% dextrose with 40 millimoles of potassium. So let's just double check, are we obeying my potassium rules? So it's 40 millimoles in a litre, so I'm happy with the concentration there. It's 40 millimoles, so the fastest I can give this is over 4 hours, and I'm actually giving it over 12 hours, so that's great. And glucose, we've taken care of his glucose requirements for the day, and 0.9% saline and 20 millimoles of potassium. So again, we've given our potassium, so I haven't concentrated it too much. And similarly, we haven't given it more than 2 hours, faster than 2 hours. So therefore, I'm quite happy with this, with the potassium rules in this case. The only thing to note is that we have given quite a lot of sodium chloride. So in our patient, he actually did not have any comorbidities. So therefore, giving them a little bit of extra sodium chloride isn't something that's too dangerous necessarily. It is something to keep an eye on, but they should be able to excrete it through their usually normally well-functioning kidneys. Then I tried to optimize it a little bit. So this was another solution that I came up with. Again, we've undershot their potassium a little bit this time round by giving them 500 mils of potassium. I've undershot their sodium chloride this time round, but we've only given them 500 mils of Hartmann's along with 500 mils of dextrose and 1 litre of dextrose. And as you can see, in both instances, I'm following the potassium rules. I'm not giving it too quickly. We're giving them a little bit more glucose, but we have underdosed their sodium chloride very slightly. But perhaps something that you could do, especially if you have given your patients also sodium chloride the day before. But do remember that if they are dehydrated, the dextrose is not going to do a good job at rehydrating them. Similarly, now you've got dextrose 5% plus 40 millimoles, and you want to give them some saline, you want to give them some Hartmann's. That way we've given them quite a lot of fluid, so we're giving them 2 litres. We're coming up to about 143 to 133 plus 62.5 of the potassium. Finally, 50 grams of glucose over 24 hours. Again, just checking out potassium rules in place. Okay, it's in 1 litre, that one's in 500 mils. So again, in both cases, we haven't exceeded the 40 millimole per litre concentration, and we haven't given it too fast. In this case, the limit would be 4 hours. In this case, the limit would be 2 hours. Something you may come across on the wards is a option that some doctors opt for, which is 2 salty, 1 sweet. So essentially what that is 2 saline bags and 1 glucose bag, and you add 20 millimoles of potassium to each one and run them all over 8 hours. It is something that you might consider doing, but you do run the risk of overloading your patient, especially if you're giving this days on end. So you can see we have grossly overestimated their sodium chloride requirements, and they're getting an enormous amount of fluid. Their potassium requirements haven't really been met, but again, as long as we're keeping an eye on their use and ease, it's not something we need to necessarily stress about. So going on to the next case. There we go. So in this instance, we have a 92-year-old female. She's seen in the geriatric ward with pneumonia, and she's being treated with tazocin 4.5 IV TDS. She's confused. She takes very minimal amounts orally. She's got congestive heart failure, hypertension, dementia, and AF. She's taking bisoprolol, amlodipine, aspirin, and apixaban. On examination, we can see that she's apyrexial generally. Heart rate's not tachycardic. BP is 125/90, respirates 20, O2 sats at 94%. She's on 4 litres of nasal cannulas. JVP is non-elevated. She's got reduced skin turgor and dry mucous membranes, crackles in the right lung base. Abdomen is soft, non-tender. Pulse is irregular, and the weight is 50 kilograms. So looking at our social history, she lives in a residential home. Diuretics are held on admission. So let's have a look at her bloods. So she's slightly hyponatremic. Potassium is 48. Creatinine is 202. Urea is 12.7. She got CRP of 101. Chest X-ray shows right lower lobe pneumonia. So, write one prescription for one fluid that would be most appropriate to deliver this patient on this presentation. Pause this, give this a go. We'll reconvene in a few minutes and have a think about what this patient's needs are, what indication you'll be prescribing for, and how you may be able to meet those requirements with the options that you have available. And remember to consult your section on the BNF for fluids and electrolytes. So hopefully you've had a chance to have a go at that. What that looks like essentially is, well, it's a surprise, I'll be telling you in a few minutes. What I do want to tell you about is about fluid run times, and this is something that is pertinent in this case. So when it comes to, considering the rates of fluid emissions, no one size will fit all. But these are some of the things you may use in common practice. So for instance, with rhesus fluids, you will typically give a bolus over 15 minutes, at the most 30 minutes. Then you want to give maintenance fluids over 8 to 12 hours, and you want to hydrate them through the day. If they're dehydrated, or they've got AKI or they're hypokalemic, generally you're happy to be a little bit more aggressive with that. So that looks like it's not quite maintenance fluid and it's not quite rhesus fluid. So like I said, something in between. So 4 to 6 hours is a good rule of thumb there. But again, with AKI, you want to try and be aggressive if you can. So anything between 1 and 8 hours could be appropriate, but you would probably be, if you're managing something like hypokalemia, you would probably be limited by your potassium and how much you've prescribed. So remember, if we're prescribing 40 millimoles of potassium, we're limited really to 4 hours at the fastest that we can give it. But remember also that, in AKI, typically that presents with hyperkalemia. So do keep an eye on where the trend is and which direction it's headed in. Also, similarly, we may have fixed indications. So DK has its own fluid pathway. But if we have a patient who's frail or elderly or risk of overload, you don't want to give more than 1 liter any quicker than 8 hours. It does say 10 to 12 hours there, but if you did give it anything more than 8 hours, you'd really be worrying about your patient's state. So you're really running the risk of overload there. And I think that would be enough to probably lose marks in the PSA. So if you have a patient who's perfectly healthy, they don't have any issues at all, and you just want to really rehydrate them, you can just say to your nurses that I would like to give this fluid set stat, and the only limiting factor will be whether you have any pressure available on the bag, how wide your cannula is. If you give something centrally, you could probably lose a bag of liter into someone's central catheter within 5 minutes or less. So let's have a look at our question now. So have a think about that. Maybe you want to adjust your answer. So we know that in this patient, we don't want to identify our indication first. So clearly she's dehydrated, but she's not unstable. She's living somewhere between routine and rhesus in the land of replacement therapy. So we look for any contraindications or cautions about fluids. So we're looking for any signs of fluid overload. So we can see she's confused, she's not drinking much, but she has got reduced skin turgor, and she looks like she's got a bit of an AKI picture coming up as well. But we do want to be a little bit cautious, because if you have a look, she's 92 years old, she's got congestive heart failure, but we have ruled out the fact that she's not currently fluid overloaded with her chest x-ray. So what do we want to do? We're looking at her potassium, and it's okay, so we would make sure we don't want to give any potassium. But she is slightly hyponatremic, so maybe that rules out some of our options and directs us towards what we want to prescribe. So we want to give her some sodium and avoid potassium. So the question is, what fluid do we give and how long are we going to give it for? So if you haven't had a chance to commit to something, now would be your chance before we reveal the answers. So the best way to approach this question is probably with a question about her routine replacement and then adapt accordingly. So she's minimal amount, so we don't really need to think about glucose at this stage, but we do want to hydrate her because she's showing obvious signs of dehydration. So what does that look like? So replacement. This is a complex replacement therapy option. So glucose would be out of the picture. The reason why is because it was likely going to make her hyponatremia worse and it would possibly overload her. And given that she's eating a little bit, this may not be needed. Potassium, again, is out of the picture. She's already borderline hyperkalemic. She's on the upper end and she's got AKI, so you expected that maybe to rocket upwards. So if you give some potassium, it could cause issues. Her weight is 50 kilograms, so we want to aim somewhere around there, maybe a little bit less if we're being a bit cautious. And the fluid choice. So we can give sodium chloride 0.9% or Hartmann's. Again, between the two of them, you'd probably want to opt for sodium chloride to optimize the treatment, just because we can see that her potassium is on the upper end of normal. But again, you would probably still get the marks if you provided Hartmann's as your option. Avoid potassium, glucose, and hypertonic saline, all because there's for the reasons we've discussed already. We're going to give the volume up to 1 liter due to risk of overload, and probably reassess her at that stage. And the rate, we don't want to give this any faster than 8 hours. So anything less would really, you'd run the risk of precipitating overload. So you want to stretch the fluids out over a long period of time, given her heart failure and give her frailty. So let's have a look. This is one option that you could provide. This is what I went with. So 1 litre of 0.9% saline over 12 hours. Or you could argue that 100 mils of 0.9% saline over an hour would equate to a very similar preparation. I hope that's okay. Again, the way these questions are typically marked is there's a bunch of examiners that get in a room to discuss these things. So if there's a justifiable way that you prescribe it and it sounds reasonable, hopefully you should get the marks. But remember that, if you have a patient with congestive cardiac failure or they're particularly frail, you want to avoid giving too much fluid, and you want to avoid giving too much fluid too quickly. So let's have a look at the next scenario. We are coming to the end now. So IV fluids 3. So we have a 43-year-old male who was admitted with right iliac fossa pain radiating towards the umbilical region. He's got an umbilical hernia. He's made nil by mouth and his stomach's been decompressed with an NG tube. So it's not something that we probably want to be giving fluids down, considering we're decompressing his stomach. So temperature was 37.4, heart rate was 85, and BP is 134/75. His respirate's 18, and his O2 sats are 96%. So JVP is not visible. He's got dry mucous membranes. Chest sounds are normal. The abdomen is distended and tender with tinkling bowel sounds. Please write 1 IV fluid. That would be most appropriate prescribed in this case. What I will do is give you his bloods. So that's what they look like. Have a look at those, see what you think is out of range, and decide your indication, decide what you're going to replace or provide, and decide what you want to go with, which regime you're going to go with, and we'll compare answers shortly. So feel free to pause the video here and we'll reconvene shortly. So the way that I would approach this question is, first of all, I would be looking for any signs of compromise using an ATE approach. So I've had a look through his OBS and nothing particularly stands out. It doesn't look like he needs rhesus fluid, so our 500 mils of saline that we could have given is kind of off the table. So we could give something a bit more complex. So looking at his patient story, we can see that he's apparently dehydrated. His potassium is on the lower side, so this may be something that we want to consider correcting. But again, he's got a bit of an AKI picture going on, so it's something that we need to consider. So when it comes, okay guys, so I think the best way to approach this question is really to just firstly establish the goals of our management. So one, we recognize that he's dehydrated. We've recognized that he's in AKI, and we've also recognized that at the moment he's hypokalemic. So those are 3 things we want to try and correct with our fluids. So what fluid options do we have that try and deal with those? So we can start off with Hartmann's. is that a good option here? Well, we're only giving 5 millimoles of potassium, and that's maybe not quite enough in this instance to correct his quite significant hypokalemia. Um, and it's not a type of fluid that we can add potassium to either. So maybe in this instance, it's best to avoid Hartmann's. You may get some marks for it, but I don't think you'd be able to get full marks for something like Hartmann's in this case. Similarly, so what can we give potassium? And we can give it in glucose, or we can give it in saline. So when we give it in glucose, the risk is that since it's hypotonic, you're going to drive more fluid away from the intravascular space. It's not going to be the most optimal management for AKI. We need to give something isotonic that's going to keep the fluid in the vascular space. And the best way to do that is by giving something isotonic like 0.9% sodium chloride. So now we want to give it quite quickly since this patient's dehydrated in AKI. So there is a limiting factor which we mentioned previously, and that is the potassium. So if we give 40 millimoles of potassium, like we mentioned, I'm sure you can already tell me the fastest we can give that is 4 hours. And if we gave 20 millimoles of potassium in that 1 liter, we could give it a little bit quicker. We can actually give it over 2 hours this time around. So both of those should score you the maximum amount of marks in a question like this in the PSA. So I hope that was useful. That is the solution in this instance. So either of those options would work for you. So I'm just going to move on to a summary slide. So just having a look at our summary slide. So the only thing that's not on here really is rhesus fluids. And just it's important to remember to recognize those signs of hypovolemic shock and when to give 500 mils of 0.9% saline over 15 minutes. Having a look at that, 0.9% saline 1 liter is similar to your O negative. So if you're not sure what to do, that's a good place to start and adjust accordingly. Make sure you monitor your clinical status, fluid output, using these VBGs throughout when you are prescribing these for patients. Rhesus fluids, like we've mentioned, routine fluids, it's 25 to 30 mils per kilogram per day. It's sodium, chloride, and potassium all requiring 1 millimole, and glucose of 50 to 100 grams. Fluid choices are Hartmann's. It has slightly less sodium chloride, but it does have a little bit more potassium and a little bit more lactate, whereas sodium chloride contains about 150 or so millimoles of sodium chloride in a bag. Glucose 5% dextrose. Remember, that is generally for routine replacement or hyponatremia. It's hypotonic, so make sure you avoid it if your patient's dehydrated, if your patient's fluid overloaded, or if your patient's hyponatremic. And probably one of the most important things you could take away from this session is the potassium rules. So the maximum concentration you can give it in is in 40 millimoles per liter and 10 millimoles per hour. It can only be added to dextrose or sodium chloride. And the rates that we can give it in, so I guess the most important one is generally if your patient's dehydrated in AKI, you want to give your fluids quite quickly. Maintenance fluids should be spread over the day. And frail patients, elderly patients, patients with cardiac failure, you want to think about stretching out your fluid regime over the course of 8 to 12 hours. So I hope you found that useful. Review these questions and hopefully we might be able to put some more out very shortly. If you have any other questions, please feel free to contact us. I've included this summary slide here, so you can take a screenshot of that. This is the NICE algorithm. And finally, this is some other resources that I found useful. So you can use the Pulse Notes guide on IV fluids, which I found quite interesting. NICE guidance on IV fluids is already available, which I'm sure you know about. And there is actually a script module on IV fluids. So if you're not keen on script, this is probably one of the few modules that you probably want to spend some time doing just because it's so alien to so many of us. So I hope you enjoyed that. Thank you so much for listening so attentively. If you have any issues or have any feedback for us, get in touch. We'll be really keen to hear from you. Take care.